It's in the mandible, you have the cortical thickness, you have the cancellous. It's a very straightforward case, everyone can do it. I have an advice for new implant placers. Try to go for upper premolars. There is no anatomical boundary, even if you go full length, don't go, but even if you go, nothing will happen. 20 millimeters, even if you drill, nothing will happen. There is no anatomical boundary. So premolars is usually the best situation to start placing implants. So place as many premolars as you can. The second safest is always the molar. But just be careful about this. Maybe we'll do another session if you invite me again. We'll do another session about one day only discussing about the treatment planning. Nothing else. So this is a case, a traumatic case. Like this is just a case for socket grafting. I'm trying to show you, and this is the first and the easiest procedure to learn. If you want to learn grafting, start with socket grafting. And also, I'll give you a tip. If you have a friend who is an ortho, not ortho, but ortho for the bone, they get grafts really cheap because they get it in kilos. So you can always borrow the graft from there and you can use it in the patient, especially in socket grafting. Ask for HA, hydroxyapatite. I think in India, because I have a brother who's actually an orthosurgeon, and there were they have really good products, and I think 5,000 Indian rupees you will get almost half kilo of hydroxyapatite. So it's very cheap, and they sell it the same thing in a smaller vial to us, double the price. So it's like professional criticism which you have. So try to have, or at least try to make friends in the ortho field. Buy a graft, distribute among yourselves, and start this simple procedure. So all you need to do is extract the tooth. If it's a traumatic extraction, there are very many ways you can do a traumatic extraction. So you can split it into half, individual, or you can just do the conventional way by luxating it. You can use luxators, there are approximators, there are so many things. So you can split it and you can extract it one by one, single piece, then fix it, place the graft, place the membrane, suture it, it's done. You have an ideal buccal width, and this is exactly the case, sir, for you for lapless surgery. In such situation, when you have very good amount of bone, buccal-lingual thickness, you can easily place lapless. So this is the second situation. So in this second situation where there is slight resorption, you can go a size smaller, or you can create a platform and then place it. So these are the two ways. Always remember, what are you compensating for? Are you compensating for the bone, resorbed bone, or you are compensating for the resorbed tissues? Because in the next classification, the next one, okay, this is the 3A. What in this situation? Can I do the same thing? Can I create a platform and then place it up? Can it be done? Yes, it can be done. I did it many times. But you're not supposed to do it. The problem is, again, what are you compensating? When bone resorbs, tissue also resorbs. So here is where you have to do the masking of pink porcelain, which is not acceptable ideally. So if I do this, if I create like a platform, place an implant narrow diameter, I will have two complications in the patient. If it's a stress-bearing area, the narrow diameter will not be optimal for load transfer because it's very narrow. The second thing is I have to also compensate for the tissues, which I have to use a longer crown with pink porcelain. In some cases, old females, maybe it's acceptable, but young patients are very fine. So implantology is very subjective in terms of patients also. That's why when I told you the 4 criteria, know your patients, who you are dealing with. So what's the best way to deal with the patients to build what you don't have? This is an easy procedure. It's called as a sausage technique, particulate graft. I think Drew already showed you how to do it in one of the cases that he was telling. So you take it, the anterior case. So you take it, you have the membrane, you place the autogenous graft, you do the xeno, you fix the titanium mesh, or you want to use a resorbable membrane. Resorbable is always preferred. To use, again, like a small tip. If someone comes and tells you, to use a titanium mesh, what is the criteria? The only criteria is thick tissues. If you don't have thick tissues, the membrane will just open up. Again, no blood supply. Everything can be tracked down. The second is onlay grafts. Even for onlay grafts, you need to have better blood supply. So any grafting procedure that you will do, try to comprehend the tissues first, whether they will be able to close, you will be able to close it, whether you have the decent amount of keratized tissues, or whether it's not there. So this is one of the products that don't have, that you can use to build it. So it's like a cover screw, you fix it with the membrane, you throw it, you do one periostal suture, and you secure the graft. So nothing fancy, and it's cost effective. Which you'll have a look at in the video. I cannot tell you all the techniques, unfortunately, because I'm really tight on time. It's supposed to be a very long lecture, unfortunately. If you want, you can come and listen to me in Jalandhar. I'm going on 31st on Jalandhar. They asked me for one full day. So everything will be there in much more detail. So this is exactly the class 3 part classification. So you do the particulate graft, you fix the membrane, and you have it. Then this is a second product, it's a narrow healing apartment. So you can do like connective tissue grafting procedures or mucoderm, or you can do buttonhole technique and all those techniques with this. I hope you are enjoying the lectures. I think everyone is looking so sad. I should have kept it this information. I shouldn't have shared all the information with you. Little by little, it's okay. Like too much information, like you get mesmerized. Okay, what this guy is talking about? So the concept is to actually bulk up the tissues here. So increase the keratized tissue. You can. That's why I told you to learn connective tissue grafting techniques. Please, please tell everyone to organize this grafting or suturing technique classes. If you learn 5 sutures, you can do almost everything. Interrupted, everyone is using it. X sutures, figure of 8. Horizontal mattress, vertical mattress. That's it. Every suture has a different indication in terms of the stresses on the flap, how much you want to release and how much you want to de-stress the flap. So all these techniques are, and continuous also. Continuous interlock. So these are some of the procedures that you can do. That technique, the last one is an end pull technique. So when you have lots of tissues but you don't have the bulk, you place like collagen membrane and try it in your patients. Like at least try to have one of this technique every time with your patients. If you're coming like it's quite easy to learn. So this is a full portfolio about zero bone loss. And there's also other techniques like bridge split. And then this is the last. Like this is too invasive, but again, this is like I used to hate basal implant guys, but this is the only condition which is indicated for basal cases because you cannot do anything in such patients. As a conventional 2-piece dentist, what can you do? You can recommend me, like even you have lots of experienced doctors here, nothing will work. You can't do a split. It's impossible to do vertical augmentation. So these cases are good with basal. So you can do something called as minimal basal. Basal also you can have. It's a money-making machine. The richest dentists in the world I have met are from basal because they don't have any inventory. They place like 50 implants in the mouth, take impression, third day the patient is out. Yeah, you are wrong. Don't speak in that, okay? You are wrong. But it's very limited.
What about zygomatic implants?
Zygomatic is also good. But how can you do zygomatic in mandible? So this is another classification. So usually the classification D1, D2, D3 doesn't work. It doesn't work practically. Because whenever you drill, you will not encounter one type of bone. You will always encounter mixed bone. So technically, it's 9 classifications of bone. It's not 4 classifications. So this is the 9 classification of bone. So it's about the thickness of the cortex you will encounter, and the second one is about the density inside. How dense is the cortex? So this is the 9. So this is actually the thickness, like when you have cortical thickness, each cortical thickness from 1 millimeter to 2 millimeter, and you have what's inside, how dense is the bone inside. So accordingly, you have to also govern your drilling protocol. So now, if in this situation, when like this is the classic hollow tube mandible case, or osteoporotic mandible. In this situation, when you try to drill it, as soon as you puncture the cortex, the drill will just slip in. And now the doctor is confused if I have to under drill it or if I have to drill it optimally. Because if you under drill it and you place an implant, it will exert too much pressure on the cortical plates, and because of this pressure, the bone will resolve. And if you over drill it, you will never have a primary stable. So this is the incidences. I think you guys had enough. This is just like how you can use the implant, what feature are what. So when you have the coronal aspect, what are the thread designs you have? Square shape or reverse buttress or different designs. And in the apical design, what are the features that you have? V-shaped trapezoidal thread, and how you can use it in different bone densities by drilling it. I think you guys are already. Okay, I'll stop it here. Maybe next time we'll take it.